A renal halo is a thin, hypoechoic outer rim of the cortex, which can be seen in patients with or without any evidence of renal disease. Presence of a renal halo should be noted in the patient record. Cats with FIP may show a subcapsular halo. This video is from a 14-year-old neutered male cat under treatment for chronic renal failure and anemia. The patient has a medullary rim sign and a dilated renal pelvis suggesting current pyelonephritis. An outer medullary rim sign is the appearance of a hyperechoic band at the junction of the cortex and medulla. It is consistent with mineralization, necrosis, congestion, or hemorrhage. This is a nonspecific indication of current or past renal damage or injury. The patient's symptoms, blood work, and urinalysis help indicate the presence of current disease. The medullary rim sign may be seen in apparently normal cats and seems to be associated with mineral deposits in the lumen of the medulla. A medullary band sign is a hyperechoic line occurring within the inner medulla and has been histologically associated with hemorrhage, congestion, edema, and necrosis resulting from infection with leptospirosis. The medullary band sign is not always present in cases of lepto. The kidneys appear normal in this 1.5-year-old lab mix, showing recurrent episodes of fever of unknown origin over a 3-month period. The dog tested positive for leptospirosis and responded to treatment. Subcapsular edema or fluid may be seen with trauma, infection, acute obstruction, toxins, or neoplasia. This video is from a 41-pound healer. Note subcapsular fluid at the caudal pole and the dilation of the renal pelvis suggesting pyelonephritis. This video is from a 2-year-old, 62-pound female Rottweiler with severe congenital aortic stenosis. Note that the renal cortex is hyperechoic compared to normal liver parenchyma. Changes in renal echogenicity cannot be associated with renal function without considering the patient's symptoms, blood results, and urinalysis results. Biopsy may be necessary to support renal disease or direct treatment. With toxins, lymphoma, and FIP, the cortex will appear hyperechoic, while the medulla remains hypoechoic. The cortex may also appear hyperechoic with glomerular and interstitial nephritis, leptospirosis, acute tubular necrosis from antifreeze, grapes, or lilies, and nephrocalcinosis. The cat in this video has renal lymphoma. Note that the kidney seems rounded and bulging. The cortex is hyperechoic. Measurements exceed normal in length and width. Biopsy of the renal cortex was definitive for lymphoma. The dog in this image has antifreeze poisoning. The cat in this image has end-stage chronic renal disease. This video is from a 5-year-old neutered male Shar-Pei presented with fever, lethargy, and an elevation of BUN and creatinine. A familial renal reactive amyloidosis secondary to chronic infection or non-infectious inflammatory disease occurs in about 23% of the Shar-Pei breed in the United States. Amyloid deposits can occur in the kidneys, liver, spleen, pancreas, adrenal glands, thyroid, myocardium, prostate, lymph nodes, and gastrointestinal tract. Ultrasound may show a hypoechoic liver and hyperechoic renal cortex. Biopsy proves the presence of amyloidosis of the cortex in about 64% of cases. Amyloid deposits can be limited to the medulla, but do not biopsy the medulla. Typical clinical signs are polyuria, polydipsia, anorexia, vomiting, dehydration, weight loss, weakness, and lethargy. A hyperechoic medulla is seen with chronic pyelonephritis, congenital renal dysplasia, amyloidosis, and end-stage renal failure. With chronic renal disease, the cortex and part of the medulla become hyperechoic, leading to a loss of corticomedullary distinction. This appearance causes the cortex to look thickened. Color flow Doppler can be used to identify the arcuate vessels and locate the separation between cortex and medulla. This video is from a 13-year-old neutered male cat with chronic renal failure. Dilation of the renal pelvis suggests chronic pyelonephritis as the cause of symptoms. Mineralizations are usually seen in the renal parenchyma and not the renal pelvis. Mineralizations can occur in the cortex or medulla. Local hyperechoic foci and acoustic shadowing may be seen. Mineralizations of the parenchyma do not require treatment. Kidney stones or nephroliths are actually located within the renal pelvis and present danger of causing obstruction by passing into the ureter. Anechoic fluid of the renal pelvis can usually be seen surrounding the stone. There is also an acoustic shadow from the stone. Kidney stones can also be a source of chronic urinary tract infection. Mineralizations are in the parenchyma of the medulla or cortex and do not present a risk of renal obstruction. This video is from an 8-year-old spayed female Shih Tzu with renal and cystic calculi on radiographs. The owners had not noted any symptoms. Mild dilation of the renal pelvis emphasizes the hyperechoic surface of the stone in the pelvis. Extensive mineralizations of the medulla are also present. Most nephroliths in cats do not cause major clinical problems. About 50% of cats with chronic renal disease will have nephroliths, which do not seem to accelerate the progress of renal disease. Nephroliths should be surgically removed if they are causing renal pelvic dilation and complete or partial obstruction to renal flow. Removal of nephroliths can also be considered if the nephroliths are associated with persistent bacterial urinary tract infections, that are not responsive to antimicrobial therapy. Cutting through renal tissue to remove a nephrolith can reduce renal function by 20 to 40%, depending on how much of the kidney has to be cut. If nephroliths can be removed through the renal pelvis, there is little or no effect on renal function. This video shows a staghorn calculi in the renal pelvis of the right kidney of a neutered male basset hound presented with hematuria. The calculi resembles a staghorn fern. The dog had been on chronic steroids for knee problems and now has a chronic pyelonephritis. Treatment recommendations included surgical removal of the stone and long-term antibiotics.